Awesome. Thank you so much, Greg. Nice to see everybody this morning. I'm on the West Coast in California. My name is Dr. Suki Padda. I am a thoracic medical oncologist and director of thoracic medical oncology at Cedars-Sinai Medical Center in Los Angeles. So this is a LungNet breakout session. I heard there wasn't a dedicated talk for LungNets. So I do want to start by giving you a quick slide presentation, put about 10 slides together. I've also received a variety of questions in advance that were of interest to the audience. So we'll do our best to get through what we can in the next 30 minutes. And I apologize in advance if we don't get to your question. So there's some unique characteristics of neuroendocrine tumors of lung origin. So I did want to highlight some of those for all of you this morning, although it may be afternoon where you're located. First of all is learning the language of lung neuroendocrine tumors, because the classification scheme for lung neuroendocrine tumors is quite different from gastroenteropancreatic neuroendocrine tumors, and it can be confusing. So lung neuroendocrine tumors are classified when the pathologist looks under the microscope. They say, does this look like a neuroendocrine tumor based on the shape, the size, etc. So that's one thing. The other thing they're looking at to grade the tumor into the different buckets of carcinoid versus higher grade neuroendocrine cancers is something called the mitotic count in a particular surface area, which gives a sense of how many cells are active in that particular sample and dividing and growing. And the second thing is a characteristic called necrosis, which means within the pathology sample or tissue sample that there are areas of dead tumor cells, meaning that they are kind of outgrowing their blood vessel supply. So unlike GEP-NETs or GI or pancreatic nets, we do not use the Ki-67 proliferation rates for our classification. So that's a major distinction. Sometimes it can help us categorize, is this a lower grade tumor or a higher grade tumor? But beyond that, it's not validated to put it in more precise buckets. So on the left, we have well-differentiated neuroendocrine tumors, and that includes typical carcinoid, or low grade, or atypical carcinoid, which is intermediate grade. And on the right are poorly differentiated neuroendocrine carcinomas. So those things are like high grade or grade 3 small cell lung carcinoma or large cell neuroendocrine carcinoma. So as you can see, the naming is a little bit confusing. So I just wanted to go through that to begin with. How do lung neuroendocrine tumors present? So they're presenting in the lung. 30% of them are peripheral, as you can see here. They're not close to any structures and not close to any airways. And most of the time when patients present, they don't have any symptoms. And this has been found incidentally, either by imaging done for some other reason. However, in 60 to 70%, the tumors are more central, as we can see here. So they're irritating the airway in some way. So those can cause symptoms, cough, wheezing, even coughing up blood on occasion. And some patients can have recurrent pneumonias. We know neuroendocrine cells have capabilities of secreting hormones. It doesn't happen as frequently for patients with lung neuroendocrine tumors. The minority may present with carcinoid syndrome, which is excess serotonin secretion, or Cushing syndrome, which is excess cortisol, which is like a stress hormone. So that's some unique characteristics of the presentation of patients with lung neuroendocrine tumors. So what is a workup for a suspected lung neuroendocrine tumor? Since we're dealing with the lung, of course, a CT chest, ideally with contrast, is key. And then we want to look for any evidence of distant spread. So an MRI of the abdomen is fine, or if a CT is done, it has to be done very specifically in this triphasic contrast, because if the neuroendocrine tumor of the lung has gone to the liver, we see that best in the arterial phase of contrast. So we have to ask our radiologist very specifically to do that if we're suspecting a lung carcinoid tumor. We need a biopsy, of course. We need to prove this is a carcinoid tumor because we know that if we look at all lung tumors, lung carcinoid is only about less than 2% of those tumors. So it's very important that we confirm what we're dealing with to tailor the treatment plan. And then if this is a lung neuroendocrine tumor, what is the grade? Is it in the carcinoid range, or is this a more poorly differentiated neuroendocrine carcinoma like small cell or large cell? If it is a carcinoid tumor, many of you are probably familiar with somatostatin receptor PETs with 68 gallium or 64 copper, and that also gives us a global assessment of the disease at diagnosis. So how are LungNETs treated? I think multidisciplinary tumor boards are key for any neuroendocrine tumor. This includes lung neuroendocrine tumors. There are many disciplines that need to be involved for the care of a patient with a lung neuroendocrine tumor. So that's just represented in the schema here. So when do we do surgery for lung neuroendocrine tumors? When are we reaching out to our thoracic surgeons? So generally it's when there is local disease that can be completely resected with negative margins. And so when a patient is being sent to the thoracic surgeon, they're also looking how well will this patient do with surgery? What's their daily functional status? How active are they? What does the pulmonary function test look like? How are they going to be able to tolerate taking a part of the lung out? Sometimes it's an entire lobe. Sometimes it's more than a single lobe. Some patients need cardiac testing if they have any heart conditions previously. And the thoracic surgeon will talk about different surgical approaches. Some of the surgeries require an open surgery, so that's a larger scar. Others can be minimally invasive or even done with a robot. And again, there's different types of surgical resections. So some you're taking the entire lobe of the lung out, and other times they can only oftentimes take even part of the lobe. We call that a sublobar resection. The one thing that's very important is that during the surgery or before the surgery, sometime, that there is an evaluation of the lymph nodes, because we want to make sure that we're not missing any occult cancer that may have metastasized to the lymph nodes. What if a lung neuroendocrine tumor is not resectable and or metastatic? Then what are the treatment options? So active surveillance may be an option. There are several decision factors we look at when we're starting systemic therapy. Sometimes we're looking at the pace of the disease. If we have older scans to compare to, we're looking at the tumor burden. Are any organs at risk where we need to start treatment more quickly? With the patient in front of us, what symptoms do they have? How are they feeling? And then, of course, we know that sometimes functional syndromes can occur where the tumor is secreting hormones, and that may push us to start treatment rather than surveillance. Well, what about treatment options? What treatment options do we have? One is targeting somatostatin receptors. Somatostatin receptors are generally expressed on lung carcinoid tumors. So there's somatostatin analogs. We tend to use those off-label, octreotide, lanreotide. There was actually a part of a randomized phase 3 trial that supported use of these kinds of drugs specifically for patients with lung neuroendocrine tumors. There's also a targeted radiation therapy. We call these like radiopharmaceuticals or peptide receptor radionuclide therapy. And I'll tell you about a very interesting clinical trial that I'm conducting with my colleague at UCSF, Dr. Hope. And then there's other drugs like targeting the mTOR pathway. In fact, everolimus is the only FDA-approved therapy for patients with lung neuroendocrine tumors. There's also chemotherapy options. Maybe targeting vasculature may be helpful. There's some data that suggests that maybe immunotherapy may be helpful in a subset of tumors. And so there are many options to be considered, and how we sequence those is not always completely clear as well. So I do want to highlight this trial. We know part of the issue with clinical trial development in neuroendocrine tumors is that often patients have been, with lung neuroendocrine tumors, have been excluded from really important studies. So this study is the trial I was referring to. It's enrolling patients who have unresectable or metastatic lung neuroendocrine tumors. Their tumors have to have activity on the somatostatin receptor PET scan, and they can receive a number of prior therapies, either be treatment naive or have received a number of prior therapies. And so they're randomized 1-to-1 to lutetium-177 dotatate, which is an investigational agent for this trial, versus everolimus, which is a standard of care. And we know that lutetium-177 dotatate is very effective in patients with gastroenteropancreatic neuroendocrine tumors, and actually there is an approval for that. But we don't have that level of evidence for patients with lung neuroendocrine tumors. So that's what we're trying to answer with this particular study. So this is slowly getting activated around sites around the country. This is a national study. So hopefully in the next few months, we'll see more sites active. We're also trying to open this at Cedars as we speak. So then I just want to briefly tell you about this condition that's very unique to lung neuroendocrine tumors, and it's called diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It's a mouthful. I just call it DIPNEC. And there's two ways to identify this disease. One is under the microscope with our pathology colleagues. And usually under the microscope, you can see a spectrum. You can see neuroendocrine cell overgrowth or hyperplasia. You can see tiny tumors, which we call tumorlets. They're less than 5 millimeters, but they're invade. And then you can also see, as part of the spectrum, carcinoid tumors, which are 5 millimeters or greater. So it's a spectrum of disease. So that's one way to classify it. Not everyone has the ability to get this kind of sample. So there's also clinical definition. And when you meet these patients, they've had symptoms for years to decades, even sometimes being diagnosed with asthma, having cough, wheezing. But then when you look at their CT, they have evidence of air trapping or air obstruction with a specific characteristic called mosaic attenuation seen on CT. And they have all these little lung nodules on both lungs. So that's another way to categorize DIPNEC is from a clinical perspective. So I know that there were some questions that came up over this disease spectrum, so I wanted to be sure to introduce it. So let me stop sharing, and then I can start going through some of the questions that did come up. And thank you for submitting these questions ahead of time so I can get you the precise answers. So the variety of questions that came in, and I'll do my best to get through as many as possible. So one of the questions that came in for that last spectrum of disease, DIPNEC, what is the latest information we have on it and with regards to treatment? So I can tell you for some patients with DIPNEC, when they first present to me, they'll have an invasive carcinoid tumor. And so generally, we send those patients to the thoracic surgeon to resect the carcinoid tumor. But oftentimes, you're left with little lung nodules on both sides, and we have to decide whether we can just do active surveillance or whether we need to do any more treatment in addition. And so that's really determined by two things. One is the pace of the growth of these different lung nodules. Oftentimes in DIPNEC, it's a very, very slow growth. And actually, one of the former fellows I worked with at Stanford University, Dr. Thomas Sun, just published on this in the European Respiratory Journal, showing that the growth of these nodules tend to be very slow. Of course, there's always outliers. The second thing is with regards to patient symptoms. Some of these patients have been suffering with cough and shortness of breath for years to decades. And so then you may be starting to think about, yeah, let's do something else. So there's not really good treatment paradigms, as this is increasingly recognized disease that hasn't been before. And so what I generally do, I call up my pulmonary colleague and I say, hey, can you take a look at this patient? Maybe they need some baseline pulmonary function tests to see what's going on in their lungs, how much obstruction is being caused by the DIPNEC, and considering a trial of steroids. So there's inhaled steroids, for example, that can be used, or inhaled bronchodilators to kind of expand the airway. So usually I do a trial of that for about a few months and see how the patient's doing. So a subset of patients will benefit, and that's all you'll need to do to help with their symptoms. But honestly, the majority, if they're having symptoms, we often have to do something else. And so that's where we can consider using drugs like somatostatin analogs, octreotide or lanreotide, and give patients a monthly injection. And so there have been several retrospective cohort studies that have looked at the efficacy of somatostatin analogs, with the majority showing at least a subset of patients having symptomatic improvement. So, for example, that case series I talked about from Stanford that was led by Dr. Sun, 24% of patients in that cohort received a somatostatin analog, and all of them had symptomatic improvement. So that is something that I've tried anecdotally as well in my own clinical practice. I've seen patients derive benefit from use of somatostatin analogs. So that was one of the questions that came through. I think that's a very good question. There's been no trials at all for interventional treatments in DIPNEC, so we really need more research focus around that. So I know groups of folks are definitely looking into that, including us. So then the other question came up is, what type of doctor should follow symptomatic DIPNEC after a lung carcinoid resection? And so this is a great question as well. This is an under-recognized disease that's being increasingly recognized. So some pulmonologists actually are quite familiar with DIPNEC. Some patients follow with pulmonologists, others follow with medical oncologists, and some follow with both. And then, of course, thoracic surgeons as well, if a patient has undergone a surgery, can also follow the cadence or change of the nodules over time in a patient with DIPNEC. So those were a couple of questions on DIPNEC. And so let's see what else we can take a look at that came through the questions. Oh yeah, I thought this one was super interesting. How common is it for well-differentiated lung neuroendocrine tumor, such as typical atypical carcinoid, to transform to a poorly differentiated neuroendocrine tumor like small cell lung cancer or large cell neuroendocrine cancer? So that generally doesn't happen. We don't see that kind of a switch or migration. Carcinoid tumors versus high-grade neuroendocrine carcinomas for lung are very distinct, even from a molecular level. But what we can see is that patients, as they live with their disease longer, when they're getting potentially repeat biopsies during their time to guide their clinical care, you can sometimes see that mitotic count rate go a little higher. That gives you a sense of how active the cancer is, or the Ki-67. You can also see that go higher, but not generally a complete switch. The other entity that's being recognized is tumors that look like atypical carcinoid under the microscope, but then they have a very high mitotic count rate, or Ki-67, higher than what you would expect. But when you look at the molecular data, they look more like atypical carcinoid tumors. So there's some question now that's brewing, is whether there's a similar category in lung as they have in pancreatic neuroendocrine tumors, which is called grade 3 well-differentiated neuroendocrine tumors. So it's a question. We don't have that category in lung as they do in pancreatic neuroendocrine tumors, but it is something to look out for. That may be something that will evolve in the future. There was another question, is how often are lung neuroendocrine tumor patients diagnosed with a second type of cancer? And what is that second type of cancer if they do get a second primary cancer? So there was actually very recently a publication in JAMA Oncology that was looking at the SEER registry, which is where a lot of our epidemiologic studies come from. And they looked at patients with GI, pancreatic, lung neuroendocrine tumors, and amongst about 60,000 of those patients with those tumors, 8% of those had a second primary. And of those, neuroendocrine tumors, a second primary neuroendocrine tumor was observed in 16%. Now, if you look specifically in the lung neuroendocrine tumor group, the cumulative incidence of developing a second primary cancer there was about 4.8%. They didn't report on the specific types of cancers that were most observed in patients with lung neuroendocrine tumors, but it is definitely something that does occur, second primary cancers in patients who have neuroendocrine tumors. Let me take this question as well. There was a question about everolimus. Is everolimus just used for lung neuroendocrine tumors? So everolimus is the only FDA-approved therapy for unresectable or metastatic lung neuroendocrine tumors. However, this drug is also approved for patients who have neuroendocrine tumors of pancreas origin and also gastrointestinal origin. So it's approved more broadly beyond lung, but for lung, it is the only FDA-approved therapy. And let me just do one more question, given the time limit of our session. And again, I apologize if I did not get to your question. There was a question about a low-grade carcinoid being positive on FDG PET scan. So this is not the neuroendocrine-specific PET scan, but having no evidence of protein expression of their tumor of somatostatin receptor 2 or somatostatin receptor 5. So I think this question allows me to make 2 points. One is regards to which PET do you use in patients with lung carcinoid tumors. Generally, we're using a somatostatin receptor PET like 64 copper or 68 gallium dotatate. We expect that the majority of typical carcinoid tumors will be avid or positive on a somatostatin receptor PET. But we know probably 10% of typical carcinoids and 50% of atypical carcinoids of the lung may not be. And so sometimes those tumors are positive on the standard FDG PET that is used for majority of other types of cancers. So that's one thing. The second thing is with regards to this protein expression of somatostatin receptor 2 and 5. So both the somatostatin receptor PET and these kind of protein strains are trying to get at whether there's somatostatin receptor expression on the tumor. But I will tell you that the immunohistochemistry, this protein staining on tumors of somatostatin receptors, is an evolution. So it's not always used in standard practice. Maybe some very select centers are doing this more routinely, but it is not being done broadly. And there was actually just a recent paper that came out that was looking at patients who got a somatostatin receptor PET and also get tested for somatostatin receptor proteins with immunohistochemistry on the tissue itself. And there was only about a 75% concordance. So it's not perfect. So I think we'll learn more about these tests as more studies are done. Okay, from Carol, what of 0 somatostatin receptor 2 or 5 receptors and path deemed for typical carcinoid, especially if original is very FDG avid? So again, this is an area of ongoing research. We don't have all the details. Even for patients with typical and atypical carcinoid, all those patients as well aren't getting a somatostatin receptor PET and FDG PET at diagnosis. One time you're getting just one or the other. So a lot of these questions of how concordance with somatostatin receptor protein expression, how is that concordant or discordant with FDG PET? Similarly with somatostatin receptor PET, this is an ongoing research question. It's a very, very good question whether we can also rely on protein expression in tumor tissue testing. So very good question, Carol. Excellent. Thank you. Take care, everyone. Thanks for your time. Bye-bye.